So this picture over here on the right is me as a surgical resident. And I had a dog named Sam back in 1992. You can get an idea of how old that, that image is and how old I am now. And Sam was a 4-year-old golden retriever cross that was my dog and my roommate's dog. And Sam developed a mass on his side. This is not actually his mass, but it's similar. And so I did an aspirin. It came back some type of soft tissue sarcoma. I took him to surgery. And at that time, I didn't really know anything about cancer surgery. And I don't think a lot of people did really when it came to what it took to get, a curative surgery. And so basically I cut in and basically peeled out what I could. And lo and behold, about a year later, the cancer came back and he was euthanized because of that recurrence. And I know for a fact that if I were operating on Sam today, that I could have cured him, 90% chance of cure, and that he would have lived to a normal, healthy, happy age of, 13, 14 years of age. And so I still regret the way that I treated Sam. Sam was a lovely dog, and I know that I could have done better by him. And so hopefully through the pointers that I'm going to give you in this chat, you'll learn some things that'll help you avoid the same mistakes that I made when I was a surgical resident. So, so the name of my lecture is The 10 Commandments of Surgical Oncology, and I'm going to try to avoid too many jokes and puns and things, although I am a dad, and so I am going to have to tell a few, but hopefully this is going to be content rich and dad joke poor if everything goes well. So there are a couple of distinctions that I want to make, and this is not, these two definitions are not universal, but they are the way that I like to refer to recurrence and metastasis. And so recurrence, in my language, implies another tumor of the same type coming back in the same location. Generally implies that tumor cells were left behind at the original surgery. And then metastasis is another tumor of the same type in another location, which resulted from systemic spread. And so if you had an osteosarcoma that spread to the lungs, that would be metastasis. If you have multiple primary mast cell tumors on the skin, those are not metastasis necessarily. In fact, more commonly, those are multiple primary skin tumors rather than metastatic. And you can have multiple primary mast cell tumors, for example, in a Labrador or Golden Retriever, all grade 1 tumors or all low-grade tumors, and it does not affect the long-term prognosis just because you have multiple cutaneous mast cell tumors. The other question that comes in is, how do you treat them when you have 20 mast cell tumors on the skin? And we can talk about that a little bit later on. Incidentally, I'd like this to be a discussion, and so if you have questions, please put them on the chat, and Matthew is going to keep an eye on the chat to make sure that that I answer all the questions. Don't be afraid to butt in, and if you don't get our attention through the chat, you can always just unmute your microphone and ask a question, although please make sure that if you're not asking a question that you go ahead and mute your microphone. So again, recurrence is local disease, metastasis is systemic disease. So radiation therapy generally reduces recurrence. Chemotherapy generally reduces systemic metastasis. There are a couple of chemo protocols that may reduce local recurrence, but by and large, we're talking about radiation therapy for local disease and chemotherapy for systemic disease. So that's another difference that you need to be aware of, at least in my language. And the difference between radiation therapy and chemotherapy, as far as local disease and systemic disease, is pretty universal. So I want you to look at these quotes, and if you have ever found yourself in practice saying these things or thinking these things or worked for somebody who says these things, that's a problem, okay? That is a warning sign to you that maybe you aren't treating your cancer patients the best way you could. And so, and I've heard all these things before. I probably have said them before when I was a resident, before I started my surgical oncology fellowship. I would have taken out more, but I was afraid that I couldn't close it. Can you guys in the chat please just say yes if you have heard yourself say that before or heard somebody else say that? I would have taken out more, but I was afraid that I couldn't close it. And I'm gonna hopefully break you of all these things. I got out as much as I could. I thought it was a lipoma, but it turned out to be something else. We got dirty margins. Let's just hope it doesn't come back. And so again, if you could make, just respond. Yeah, I see lots and lots of yeses here, and absolutely, that's something that we all have said, and unfortunately, when you say these things, it's a sign that maybe you need to rethink the way that you're treating these guys. And again, hopefully, I'm going to give you the information and the ammunition that you can rethink those things so that you won't be saying those things. So when I talk about the 10 steps of, or 10 commandments of surgical oncology, you'll notice that informed consent makes up 3 of those steps. And I'm really all about making sure that the client has all the information that they need in order to make a good decision. And I'm going to go through each of these steps individually, but note that every time we have a fork in the road, we're going to stop and talk to the client. And again, make sure that they have all the information that they need to make a good decision. Let's say we've got Maverick. Maverick was a 5-year-old neutered bull mastiff, and he had a 3-month duration of a progressively enlarging mass in the left elbow, and he was otherwise healthy. And so I'm sure we've all seen a case like this. They're very common. And so we need to think about the way that we might treat this patient. So the first step that we always want to take when we're treating a patient is to know our enemy. And so we want to find out what we're treating. And you can't treat a patient with cancer without knowing what you're treating. You can't treat them effectively anyway. And so there are 2 different types of biopsies that we can take. One is incisional and one is excisional. And so an incisional biopsy is where we're sampling the tissue before we do curative intent treatment or curative intent surgery. And an excisional biopsy is when the tumor is removed prior to knowing the histological type and grade. One is generally a good thing and one is generally a bad thing, although not universally. So I will give you some exceptions to those rules. So the first thing that we're going to do is we're going to have an informed discussion with the client and talk about this tumor that they have to give them a little bit more information. So what are we going to discuss with them? So this mass on the side of Maverick's elbow, what are the possible differential diagnoses? And are we going to do an incisional biopsy first? And so in general, your first thought should be, yes, I always want to find out what the tumor is before I'm going to take it off. And that's going to be through an incisional biopsy or through a needle aspirate. The question that you want to ask when you're deciding whether you're going to do an incisional biopsy is, number 1, is it going to change the treatment? And number 2, will it change the owner's willingness to treat? So let's just say this mass on Maverick's elbow is a grade 3 mast cell tumor. Is that going to change our treatment? Absolutely, because a grade 3 mast cell tumor is almost certainly going to metastasize. And so chemotherapy is going to have to be somewhere in this protocol. And then if it's a grade 3 mast cell tumor, you might have some owners that are willing to treat a grade 1 or 2 mast cell tumor, but not a grade 3 mast cell tumor. So the answer to either one of these questions is yes, it will change the treatment and it will likely change the owner's willingness to treat. Now, if I had an owner who told me, look, I don't care what grade it is, I don't care what it is, I want it off and I want the best treatment possible, then that's fine. Go ahead and do a treatment that's going to be targeted to the worst case scenario. So we're going to do a wide local excision, send it off, find out what grade it is and what the histopathological type is, and then tell the owners, yes, it is a grade 3 mast cell tumor. Now we're going to have to do chemotherapy. If you have an owner that's willing to go that far, regardless of what it is, then you can go to surgery without doing without taking a biopsy first. But if the owner says, oh, I'm not sure I'm going to treat a grade 3 mast cell tumor, or you're not sure that your surgery is going to be appropriate for a grade 3 mast cell tumor, that's one that you need to get a biopsy first. So if you're doing no preoperative biopsy, you need to ask yourself the question, what is absolutely the worst tumor this is likely to be? And in that location, if it's a soft tissue tumor, probably a grade 3 mast cell tumor is the worst case scenario. Am I willing to administer a surgical treatment that will result in a local cure for a grade 3 mast cell tumor? And I'll tell you, in that location, that's tricky. Okay, a surgical cure of a grade 3 mast cell tumor in the lateral side of an elbow is not an easy proposition. And so you really need to question, am I willing to go straight to surgery? And number two, are the owners willing to treat that grade 3 mast cell tumor? If the answer to that is no, get a biopsy first. If the answer to both of those questions is yes, then go for it. All right, so named must be your fear, before banish it you can. We have to know what we're dealing with. So the next thing that we're going to do is a biopsy. We're going to find out what our enemy is before we go and do definitive treatment. So most mistakes in cancer surgery are made because of not resecting aggressively enough, because of not knowing the diagnosis prior to excision. How many of you have made that mistake? And I'm not going to type into the chat, but I'll tell you that I definitely have made that mistake. So please in the chat, just tell me yes or no if you have made that mistake, not resecting aggressively enough because you didn't know what you were treating before you treated it. Come on, don't be shy. All right, so we've got a couple of yeses there. That's fantastic. And I know that I've made all of these mistakes myself, and so I can tell you, not with a clean conscience, but with definitely with a note of I've been there, a note of sympathy that I've made these mistakes before. All right, so often the first step in making a diagnosis is cytology. And you have to know what information you can get out of cytology. And cytology is nice because it's easy to do. You don't need any special equipment. Often they don't have to be anesthetized or sedated. And you just put a needle into the tumor and collect some cells and put it on a slide and have a look. And so generally the three types of things that you can diagnose with an in-house cytology would be a lipoma. So everybody can tell, you know, when you squirt that liquid onto the slide and it's a big grease ball that smears on the slide, and then you put the alcohol, the diff quick stain, and it all washes away with the alcohol, that's likely to be a lipoma. Mast cell tumor, most of us can diagnose or can recognize those mast cell tumor granules. And with a soft tissue sarcoma, often you'll see those spindle cells. I will add on there that osteosarcomas often can be diagnosed at least by a clinical pathologist on cytology. I'm not sure that I could diagnose one, but likely a good clinical pathologist would be able to. So lipoma, mast cell tumor, soft tissue sarcoma, and osteosarcoma. Note, when you do cytology, you can never determine the grade. And so if you have a clinical pathologist that tells you that this is a well-differentiated mast cell tumor based on cytology, they're full of it. They cannot make that distinction. There's no correlation between, or not significant correlation between cytological grading of a mast cell tumor and histopathological grading of a mast cell tumor. The other problem is that you may miss the tumor and just detect surrounding fat. Also, some tumors don't exfoliate well. So sarcomas are notorious for not exfoliating well. Often mast cell tumors, you're going to see some granules. And the way that I like to do cytology is that I'll put in, either just grab the needle without the syringe or with the syringe. When I do it without the syringe, I just take the needle by the hub and run it through the tumor maybe 15 times. And what that does is that you're just going to line up a little column of cells within the needle and up into the hub, and then you squirt it out onto a slide. The benefit of using just the hub of the needle and not the syringe is that you're going to get less hemorrhage and you're going to get less distortion of the cells. So my preference, even though I showed you this photo here, my preference is just to use the needle, grab it by the hub, and run it through that tumor multiple times. All right, so this is a classic lipoma cytology, if you're lucky enough to see anything. And so we've got these big fat globules, almost no cytoplasm, certainly no nucleoli, no nucleus that you can really see. And so this is typically a lipoma. Now this tumor here is an intermuscular lipoma on the thigh of a dog. And these are commonly, a dog comes in with one thigh that's the size of a watermelon. The other thigh is normal in size. You assume it's a terrible sarcoma and you recommend an amputation or euthanasia. You need to do a very simple diagnostic test on these, and I'm sorry that I don't have a picture of it. Take a radiograph of the leg, because what you're going to see with a lipoma is a big black bubble in the middle of the leg, which is diagnostic for an intramuscular lipoma. And I've probably seen about 25 of these. You will see these in practice. And this is much easier to deal with than a sarcoma. What you're going to do here is you just make an incision on the back of the leg. And then once you make that skin incision and you see the lipoma, put all your instruments away and just scoop it out with your fingers, because there's a very important big white band of tissue in the middle here, the sciatic nerve, that you don't want to inadvertently cut. And often the sciatic nerve runs right through the middle of that intramuscular lipoma. If you have the luxury of a CT scan, these light up like the proverbial dog's testicles on a CT scan. So you can see that big black bubble of fat. The other thing you can do is do a big, deep needle aspirate. And if all you get is fat cells, then that's a pretty good diagnostic test. All right, so can I get just a note in the chat if you guys have seen these intramuscular lipomas before, just a yes or no? And I have seen lots of these before. So we've got a no here, yes, yeah, no, a couple of no's. So we've got an even 50-50 response. So if you keep an eye out for these, you will see them. And often, again, classically, you see a dog that comes in with one thigh size of a cantaloupe or a watermelon. The other thigh is normal in size. Often they're not limping at all. They're not sore at all. And you want to take a radiograph on these. You'll see that big black bubble, and then you do cytology, and that'll confirm that fat. And somebody commented, they're awesome to remove. They sure are. They really just scoop out, and you can get the whole thing out cleanly. And that's the only time I'm going to tell you you can do that during this lecture, is shell it out. That's only if you've got a lipoma. All right, so classic mast cell tumor. So we've got all these mast cell tumor granules, and this is a normal diff-quick stain. Some mast cell tumors do not, the granules don't stain very well. For the most part, though, we're going to see these classic granules in here. And again, you cannot tell a grade based on the appearance of cytology. And then this is a spindle cell tumor. So this is another soft tissue sarcoma, and you can see these spindle-shaped cells, big nucleus, prominent nucleoli. Again, you can't tell the grade, but you would get a pretty good idea that this is a soft tissue sarcoma. All right, so when you do an incisional biopsy, you want to make sure that you plan your surgery, your definitive surgery, and place your biopsy incision so that it can be easily removed. You don't want to be left with a horizontal incision on a leg that's going to be really hard to get a clean margin, because remember that that biopsy tract is going to be completely contaminated with cancer cells. All right, so make sure that you make your incision, your elliptical incision, parallel to the lines of tension. And it's always safe to get both the center of the tumor and junctional tissue. And the reason why you want to get both the center and the junctional tissue is because with certain types of tumors, like soft tissue sarcomas, the center of the tumor can be necrotic, and the junctional tissue is what's going to give you the diagnosis and also the evidence of invasion into surrounding tissues. Whereas with osteosarcomas, often the center is the diagnostic area of the tumor, and peripherally, all you're going to see is proliferative reactive bone. So the center and the junctional tissue is always a safe idea. And in one study, 30% of humans that presented to a tertiary referral center for limb salvage surgery had to have their limbs amputated because of inappropriately placed biopsy incisions. I'm sure that that happens in veterinary medicine as well. Pardon my pun here, a farewell to arms. So people that had to say goodbye to their arms and legs because of an inappropriately placed biopsy incision. All right, so if you're doing an excisional biopsy, you're treating a patient based on a guess. Okay, that's not always wrong, but remember that you are treating them based on what your guess is as to what this thing is. Be it, oh, I thought it was a lipoma, I thought it was a low-grade mast cell tumor, and it turned out to be a high-grade mast cell tumor, etc. The other big thing that I want you to avoid is drains. All right, if any of you have watched my YouTube live streams, can I get a reply on the chat? Who has seen our YouTube live streams? The people that have watched our YouTube live streams would know that I never use Penrose drains. We do not own Penrose drains in our practice. If you're going to use a drain, you'd use a closed suction drain, but rarely am I going to drain tumor excisions and certainly not biopsies. There's no reason to drain these things. And if you're going to drain, you certainly don't want to use a Penrose. And the reason why you don't want to use a Penrose, number one, they're ineffective for drainage. Number two, they allow bacteria into the wound as much as they're allowing drainage to come out. Number three, if this is a dirty margin, that means this whole area is contaminated. And so what could have been a revision surgery and a recut now has to be an amputation. All right, so the only thing Penrose drains are good for is retracting the sciatic nerve out of the way when you're doing your intramuscular lipoma. We do not own Penrose drains in our practice, literally. And so I want you to raise your right hand and promise me that you're going to stop using Penrose drains. The only exception may be some people say they still use them for cat abscesses. Okay, fair enough. I don't treat a lot of cat abscesses, but please stop using Penrose drains. 90% of the time that you're putting a drain in the wound, you don't need it. The other 10% of the time, you should be using a closed suction drain. All right, so big X on the Penrose drain. So this is a dog that came in to me for a mammary gland tumor recurrent on a previous radical mastectomy. And so this is the excision that I would have to do on a recut. Now, look what would happen if somebody put drains in. That's the size of the excision that I would have to do on a recut. So look at the comparison, and that will often change whether a surgery is doable or not, whether somebody's put drains in. And often I will get somebody come in for a recut on a dirty margin, and I say, yeah, this is no problem. It's a 6 centimeter mass or 6 centimeter incision, no problem, we'll do a recut. Then we clip the leg for surgery, and then I find out that there are drain holes 3 centimeters above and 3 centimeters below the old incision, and it completely changes the whole plan that we have to do. Okay, so no more Penrose drains, please. General biopsy principles. Okay, the first thing is when you fill out your form, give the pathologist a great history, and often we will even provide digital photographs. The reason why you want to do that, number one, it'll give the pathologist a better idea of what the tumor looks like, where it's located. You're not going to get the diagnosis of transitional cell carcinoma in the armpit of a dog, which I have had something similar before. The other thing is that the life of a pathologist would be very boring, staring into a microscope. So you want to give them something else to look at, which is going to make them take interest in your case. Really important, if the diagnosis doesn't fit the patient, call your pathologist. If the pathologist doesn't return your call, get a new pathologist. You need to have that close relationship with your pathologist. We call back and forth several times a week to our pathology lab to discuss cases. And that when you open up that line of communication, when something doesn't fit the patient, they'll give you a call and say, look, are you sure that this is blah, 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 or whatever? And then you'll say, oh, actually, no, this came from this part of the body, or we didn't think about that, whatever. And so when you open up that line of communication, number one, it's going to make both of your lives more interesting and more fun. Number two, it's going to be better for your patients. All right, so when you get your pathology report back, there are several things that you want to read out of that report. Okay, so number one, is it a tumor or is it some benign process? Number two, what is the histological diagnosis? Number three, what is the grade? And grade is predictive of behavior with a lot of different tumors. And so grade is only determined on histopathology, and for mast cell tumors, soft tissue sarcomas, osteosarcomas, melanomas, lymphomas, all kinds of different tumors, the grade is predictive of outcome. And so again, that's going to be more information that we can take back to the owner so that they can make an informed decision. And if you've done an excisional biopsy, you want to find out what the margins were. Did you get the whole thing out? All right, so Maverick's biopsy result came back a grade 2 fibrosarcoma. So the next thing we're going to want to do is a literature review. What is a literature review? Ultimately, all of the literature that we want to use ultimately comes from journal articles. So we all want to practice what's called evidence-based medicine. And evidence-based medicine means that we have results and findings that are from peer-reviewed journal articles whenever possible. We don't want to use anecdotes. We don't want to use conjecture. We don't, basically, you don't really want to use your own personal experience unless you have operated on so many of these in so many different ways that your personal experience is more than what might be present in the journal articles. Now, the problem with getting information from journal articles is that it can take, 5 years for journal articles to filter out into textbooks. The other problem is that journal articles, when I was studying for my boards, just for surgery boards, I had to read 10 different journals, every article, every month of 10 different journals for 5 years. And that's really hard to keep up with. So what we want to do is we want to distill that information out into textbooks. Your specialists hopefully are going to keep track of their own fields. And something like vin.com is really good, where you can post questions and specialists will respond and answer your questions. And in here, in specialists, I can put timeless telemedicine service, which means that you can get direct access to those specialists who are going to keep up with those journal articles and then report to you what the best treatment is. And the whole lifeblood of a specialist's entire existence is communication with primary care vets. That's what we're all about. And so if you have a specialist that is unwilling to take your emails or phone calls, get a new specialist. Okay, it's just like the pathologist. If you have somebody that won't talk to you, get a new pathologist. And for people that live in places that don't have specialists available, that's where the telemedicine services come in handy. And I can also tell you that I take a lot of information emails from all over the world, from developing countries and all over the place. And I'm happy, I'm happy to answer questions as well. Textbooks are also great. The problem with textbooks is that when I edited the oncology section of Slatter's Textbook of Surgery, from the first time that I collected an article from an author to the day that the textbook was published and on the shelves was 5 years. Okay, so the information is already 5 years old, often in textbooks, the day that they are published. So the way that we treat as a soft tissue sarcoma or osteosarcoma probably really hasn't changed that much in 5 years, but there are some things that, with advent of palladia and cancer vaccines and things like that, there is stuff that is changing. Certainly the cycle is less than 5 years. So you probably are going to want to go straight to the source and talk to the specialists and use other sources rather than textbooks when you're trying to find up to the minute information. All right, so when you're doing your literature review, what questions do you want to answer? Number one, because this is a surgical oncology lecture, is there a curative dose of surgery? The answer to that question is often with soft tissue sarcomas, mast cell tumors, things like that, there is a curative dose of surgery, at least for the primary tumor. For lymphoma or multiple myeloma or something like that, the answer to that is no, there is not a curative dose of surgery. There's other stuff that you have to do. Next question is, if you do a marginal surgery that's likely to recur if you just leave it, are there adjuvant treatments available for residual disease? And the answer to that question often is yes. And that adjuvant treatment might be chemotherapy, it might be radiation therapy, it might be, any number of different things. And so you're going to want to know if there's something else that you can do if you're not going to get a clean margin. Number three, are there gender, species, breed, and anatomical variations in tumor behavior? Let's start with gender. For example, mammary tumors in male dogs are rare, but when they happen, they are nasty. Okay, they are very, very bad or poorly behaving tumors. Species, mammary tumors in dogs tend to be much more benign than mammary tumors in cats. In contrast, mast cell tumors in cats tend to be much more benign than mast cell tumors in dogs. Okay, so these are things that you need to know. Again, we're trying to put a package together that we can then go back to the client and give them all the information that they need to make good decisions. Breeds, for example, mast cell tumors, boxers tend to have quite benign mast cell tumors, whereas Shar-Peis tend to have really nasty mast cell tumors. And then anatomical variations, mast cell tumors that occur at mucocutaneous junctions tend to be a lot worse than the ones that occur on the skin. Melanomas of the skin of a dog tend to be quite benign, but if it happens in the nail bed or in the mouth, it's really nasty. Osteosarcoma, when it happens on a digit, is relatively benign, whereas if it happens in the skin or in the mammary tissue, is horrible, the median survival time of about 2 months. So, if you don't treat these things every day, it's impossible for you to keep up with all this information. And that's where contacting your specialist is really handy. What's the likelihood of metastasis? Often that's grade dependent. And so, grade 1 soft tissue sarcoma on the extremity is never going to metastasize. That's never going anywhere. Whereas a grade 3 mast cell tumor on the extremity is very likely to metastasize. Where are metastatic lesions likely to appear? And the reason why you want to ask this question is because you're going to go on a metastasis search before you do surgery. So with any kind of sarcoma, often that's going to be to the lungs. Mast cell tumors, often to the lymph node, but also to the spleen, liver, bone marrow. Carcinomas tend to go to lymph nodes first. Okay, so knowing where those metastatic lesions are likely to occur is going to help you go on a metastasis search. Has chemotherapy been shown to improve survival? There aren't that many cases where it has. I'll give you examples: transitional cell carcinoma, osteosarcoma, lymphoma, hemangiosarcoma, multiple myeloma, maybe mammary gland tumors, maybe pulmonary tumors, but not, it's less than a dozen tumors that chemotherapy has been shown to be helpful. And so you're going to want to know that information. Are there paraneoplastic syndromes? And the classic one would be anal sac adenocarcinoma with hypercalcemia. Not only is there a paraneoplastic syndrome, but that paraneoplastic syndrome is also prognostic for survival. And so if you happen to be doing an anal sac adenocarcinoma in a dog that is also hypercalcemic, you need to know that 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 dog has a poorer prognosis and is more likely to metastasize than one that's normal calcemic. All right, so next step is staging. Don't get stage fright. All right, we want to know what the stage of our tumor is. And what is staging? Staging is determining the regional and systemic extent of the tumor. And so the easy things that we can do, lymph node aspirates. And you want to direct your staging based on your literature review or your discussion with your specialist. So lymph node aspirate is appropriate with mast cell tumors and anal sac adenocarcinomas, probably less appropriate for a soft tissue sarcoma, although they can spread to the lymph nodes. It's very, very unlikely. Chest radiographs, always a good idea, relatively fruitless with mast cell tumors. I don't think I've ever seen a mast cell tumor spread to the lung parenchyma. But if you had one in a front leg, you might see enlargement of the substernal lymph node. CT scan is definitely going to be much more sensitive than chest radiographs, but it's not widely available. Note that a lot of referral practices are happy to do CT scans on an outpatient basis. If you already have a diagnosis and you just want to do staging, a lot of referral practices are happy to take that case just to the CT scan and then send it back to you for definitive treatment. CT scan of a leg, always helpful. It's going to help you determine proximity to important structures. And so, that can be really beneficial as well. So this is a lymph node aspirate on a dog that has a mast cell tumor on the extremity, and we've aspirated the prescapular lymph node. What do we see here? All lymphocytes all varying from very mature lymphocytes to some fairly immature lymphocytes. So this is just a reactive lymph node. If we saw this lymph node full of mast cells, that would be an indication that it might have spread systemically. So full body scan, somebody asked, is really nice for some patients. You can't really do a whole body MRI easily. Whole body MRI, even with a very high speed, high quality 3 Tesla magnet, is going to take you a couple of hours. A whole body CT scan is easy. It takes about 10 minutes in our hospital. And so full body scans, the time that I love doing full body scans is when I get that 8-year-old Labrador with 20 masses on its body that we think are probably lipomas, but we want to know which ones we need to aspirate to make sure. Do a whole body CT scan on that. And again, those lipomas are going to show up so clearly as fat compared to if you have one that shows up that's actually soft tissue. You can immediately put a needle into that one or do a biopsy and find out exactly what you're dealing with. So great question. Thanks, Kate. All right, so chest radiographs. Here's the proverbial blizzard where we've got lots of snowballs in the chest. And so that's going to be very diagnostic for us that we've got metastatic disease. Not as sensitive for a CT scan, but certainly a great preliminary or screening test. And if I have a dog that comes in with a grade 1 soft tissue sarcoma on the extremity, really very little chance that it's going to metastasize, I'm not going to CT that dog. I'm just going to do a chest x-ray just to make sure that there's not something else weird going on, because I don't want to do that surgery and then find out a month later that it has mets from something else. Whereas if I have an osteosarcoma that has a high chance of metastasis to the lungs, I'm much more likely to do a CT scan. And then this is a human CT scan, and we can see a metastatic lesion here. To give you a comparison, with a CT scan, we can see lesions down to about 3 millimeters in diameter. And in an X-ray, they really need to be probably about 1 centimeter in diameter for you to be able to see them reliably. So this is a clear CT scan of a dog. That is an end-on vessel. How can I tell that that's not metastasis? I could not tell that based on this one slice, but what we do is screen through the whole scan. And if this looks more like a tube than a sphere, then that's going to be a blood vessel. Whereas if it's just a sphere and only present on 3 or 4 slices, that's more likely to be a metastatic lesion. All right, so regional extent of the tumor, the best thing that you can do is physical examination. So we're just going to palpate this thing, assess its size, because size is prognostic for certain types of tumors. We're going to look for attachment to the underlying tissue. If we move this tumor, does the whole dog move, or does the tumor move freely within the skin? And that's going to predict how hard it is to do a surgery. And then we also want to look at anatomic considerations and think about the big structures with short names. There's a saying in surgery, never cut anything you know the name of. And so that's a good rule of thumb. And so obviously we're going to have the sciatic nerve sitting back here. All right, so this is a CT scan at our hospital. This is called 3D volume rendering, which is a huge privilege and advantage when you have it available. What it does is it does a CT scan and then it assigns colors to different tissues based on a guess of what they're likely to be. And so we can see the trachea here. You can see the laryngeal cartilages there. That's the arytenoid, the cricoid cartilage sitting right there. We've got the thyroid tumor sitting here. See how close the carotid artery is to it. We've got jugular vein branching into the lingual facial and maxillary vein. We've got the mandibular salivary gland here. So it's just a beautiful image that we can get. And it's lovely to be able to have that available to us. It almost feels like we're cheating when you get into surgery. Because you're so comfortable with what it's going to look like. I know that isn't available to everybody, but there are a lot of human hospitals that are willing to do scans for you at night or on weekends or after hours. All right, so this is another dog. So this is the zygomatic arch right here. This is the mandibular salivary gland. This is the jugular vein branching into the maxillary and linguofacial veins down here. And we've got this big carotid body tumor sitting right back here behind the pharynx, and this was an unresectable tumor, so we weren't able to take that out. But again, if you went in surgically with this, you would definitely feel like, deja vu. You're cheating because you would already know exactly what to expect. All right, so now we've done the first 4 steps. We've had our first informed discussion with the client. We've done our biopsy, done our literature review, done our staging based on literature review. We go back to the client and have an informed discussion and get consent from the owners. What are our options, et cetera. So what are we going to what are we going to discuss in our informed consent? Number 1, can I do a curative intent surgery? Number 2, can I do a curative intent surgery short of an amputation? Number 3, can someone else do a curative intent surgery short of an amputation? And that's a question that you need to ask yourself. There's a saying in surgery, when all you have is a hammer, everything looks like a nail. Remember that just because you can't do it doesn't mean that somebody else can't do it. And I'm not saying that you have to refer everything, but you have to consider everything and give all the options to the owner. Interestingly, I did a quick study, just a little bit of research on Google, and I found out that of the 7 billion people in the world, 5.5 billion people live on a continent that does not have a veterinary specialist. 5.5 billion people in the world live on a continent without a veterinary specialist. And so for us to get on our high horse and say everything has to be referred, et cetera, remember that 5.5 billion people don't have geographic access to specialists, that another billion people, even though they might have one on their continent, might not have access based on geography, distance, and finances. So there are a lot of vets out there that are doing it tough without access to specialists. So I have really changed my tune. And so that's why I've started doing things like VetDojo and our live streaming so that we can teach the 90% of vets that don't have the luxury of referral to do things on their own. Okay. And if curative intent surgery cannot be done, is there an adjuvant treatment that will reduce recurrence, like radiation therapy or chemotherapy, and is that available to you? So these are all the questions that we're gonna answer for our owner. All right, so when we get into surgery, in human surgery, particularly in maxillofacial surgery, they have the luxury of having 2 different teams. They have the resection team and the reconstruction team. The resection team goes in and takes out everything that they need to in order to get a clean margin, and then they leave, and the reconstruction team comes in and tries to make sense of the mess that they've made. And the reason why they do that is because they don't want the resection team worrying about how they're going to close it when they're getting the cancer out. They want them to get the whole thing out and let somebody else worry about the reconstruction. And these 2 teams don't high-five each other on the way in and out of the theater. They hate each other because they're diabolically opposed. The reconstruction team wants it to look good. The resection team wants them to be cancer-free. Unfortunately, in veterinary medicine, we don't have that luxury. And so you have to split your brain in half into the resection team and the reconstruction team. And you have to walk into the theater and say, I'm going to cure this patient of cancer, and I'm going to do whatever it takes to get there. And then once the cancer's out, then you're going to turn off the resection team and turn on the reconstruction team, half of your brain, and then you're going to think about how you're going to put it all together. And all these options I think about before I walk into the theater, but I don't want to be worrying about this when I'm doing this, okay? If I was worried about this, I wouldn't take 8 ribs out of a cat with an injection site sarcoma. All right, and that's why I get 98.9% clean margins in my cancer surgeries. It's not because I'm a reasonably good cancer surgeon, but also I know when not to go to surgery, when there's not an option, and when I'm not going to be able to get a clean margin, or I'm not, I can't leave this open to heal by second intention. And so I want to make that decision before I walk into the theater. I don't want to be halfway through a cancer surgery and then think, oh shit, I'm not going to be able to close this. Okay? Any questions at this point? Give it a second. All right, so we'll keep going. So when we think about cancer surgery, you can dose it just like you do antibiotics. All right, high dose, low dose, medium dose. So cytoreductive surgery, grossly visible tumor remains, and this is called a debulking surgery. I want you never to do a debulking surgery again. It is a waste of time. It is the wrong thing for the patient. What you're doing is you're going to leave a big mess of cancer, gross cancer left behind. You're selecting for the more aggressive cancer cells because they're farthest away from the center. This tumor is going to get pissed off and come back more aggressively than it was before. Cytoreductive surgery, unless you're planning on following up with chemotherapy or radiation therapy, and even then, it's still not a great option. You'd much rather palliate them with intralesional steroids or chemotherapy or something like that rather than doing a cytoreductive or debulking surgery. The next dose is a marginal surgery where you're leaving microscopic tumor behind. Still not a great option unless you're going to do adjuvant therapy in the form of radiation therapy or chemotherapy. Mostly marginal surgery with malignant tumors is going to result in recurrence relatively quickly. Okay, so you want to avoid marginal surgery if you can. What you want to do is wide local excision where you stay far enough away from the tumor that you're not even close. And what I like to do is draw a line around the tumor, draw a line 3 centimeters away, close my eyes, turn off the lights and start cutting. And then when I get the whole tumor out, I turn on the lights and open my eyes. Obviously I'm joking, but you don't want to think about, you know, what you're going to encounter when you're cutting. You want to do whatever it takes to get the clean margin and then worry about how you're going to close it before you walk into the theater or after you get the tumor out, not during. Otherwise, you're going to leave cancer behind. All right, so uses the force, do or do not. There is no try. All right, you can't say I'm going to try to get clean margins. Decide that you're going to get clean margins and do whatever it takes to get there. Otherwise, don't try. Or have a very frank discussion with your owners that, I'm not going to do a great job, but we'll give it a crack. Be very resolute and clear. I'm going to get clean margins, or I'm not going to try. Or if it's somewhere in between, be very clear with the owners that you're probably going to leave cancer behind and it's probably going to come back. Unless you've got a plan to come back with metronomic chemotherapy or radiation therapy or something like that. So we don't want to make mistakes because we didn't know what we were doing or because, whatever. You want to be aggressive and cut for cure, or don't cut at all, or have a plan to clean up your dirty margins. So treatment options, plan ahead. Think about what you're going to do. All right, so we're back to Maverick here. What are our treatment options here? So there's a saying, good surgical judgment comes from experience. Experience comes from poor surgical judgment. I've got a lot of experience. I've made a lot of bad mistakes and a lot of poor judgment along the way. And what I'm hoping is that you guys can learn from my mistakes so you don't have to make your own. So I'll drag you along up the hill. All right, you don't have to make those same mistakes. And you can use things like VetDojo and Timeless and use your specialists before you get in there so that we can tell you, oh, watch out for this, look out for that, that kind of thing. All right, quick comment about amputation. If you have a dog that has 4 legs and is ambulatory on 4 legs without significant neurologic or arthritic disease, it can cope with an amputation. I don't care how big it is. I've done 80-kilo dogs that should have been 50-kilo dogs. They all walk after surgery. Funny story, I had a young couple. Their dog that was an 8-year-old Rottweiler came in with what they thought was a cruciate rupture. We took radiographs and found out that it had a proximal tibial osteosarcoma. The dog weighed 50 kilos, should have weighed about 36 kilos. So it was a big ottoman, big wombat laying on the floor. And I came out and I said, your dog's got osteosarcoma of the proximal tibia. We're going to have to do an amputation. And they said, well, how's it going to cope with an amputation? And I said, it'll be great. We have dogs that are herding sheep on 3 legs, jumping off the ends of docks and swimming, doing sheep herding trials. And the husband said to the wife, hell, we should have done this years ago. So true story. So a lot of dogs can manage with an amputation that, you would be very surprised. I've done about 1,000 large breed dog amputations, and I've had a total of 3 people come back and tell me they wish they hadn't done it. And all 3 of those had neurologic disease, and I probably wouldn't have made that decision now, knowing what I know today. So terrible joke. I can fit you with a prosthetic, a faux pas. All right, so the best option for cancer is wide local excision. Generally, with soft tissue sarcomas, you're going to have 5% recurrence in 5 years if you get clean surgical margins. So this is a big hole. Olecranon's exposed here. We can try to do axial pattern flaps. You can try to close this primarily. The fact is that this is a tricky spot. And I managed this as an open wound. Okay? That's the same dog about 10 weeks later. So this is just with second intention healing. Not saying that that's the best option in every case, but remember that dogs can heal substantially from really huge wounds. Cassie Pripich, one of my residents, who's now a surgeon in Colorado, and I did a study where we had 31 dogs, wide local excision of soft tissue sarcomas on the antebrachium, all left open to heal by second intention, including some 360-degree circumferential wounds. 29 out of 31 healed by second intention completely. We had to do 2 skin grafts, 100% clean margins, 100% tumor control. All right, so you can leave these open to heal by second intention. All right, this is one on the dorsal aspect of the carpus. Look what I've done here. I've taken the joint capsule, the tendons, everything. This dog walked completely normally. Could it chase rabbits on the savannas of Africa? I don't even know if there are rabbits in Africa. Could it survive on the plains of Africa? Maybe not. But, you know, walking through Glen Iris, going to the dog park, completely fine. Clean margin, healed by second intention, never came back. So remember that removing the extensor tendons on the dorsal aspect of the paw, front paw or back paw of a dog, completely compatible with completely normal function. All right, so this is a previous biopsy scar. So this is the right forelimb, it's not Maverick. So previous biopsy scar, we want to make sure that we're going to excise that biopsy scar. The other nice thing about the antebrachium in dogs is that you've got this antebrachial fascia right here, which is a really nice, thick, dense layer to prevent tumor extension. So when you're doing antebrachial tumors and even hind limb tumors, take that deep antebrachial fascia, and that's going to virtually guarantee you of a clean margin. Okay, and then this was just left open to heal by second intention, completely healed, no problem. All right, so this is another dog. So we've got that antebrachial fascia removed here. This is the palmar aspect, that's the elbow right there. Try to avoid exposing the olecranon if you can. It's going to heal much better and much faster. We've got that deep antebrachial fascia sitting right there, deep to that tumor, clean margin, virtually guaranteed. All right, so if you do a marginal excision, it's probably going to come back. So if you're just peeling out the tumor, it's probably going to recur. So what do we do following a marginal excision? It's a 30 to 80% recurrence following marginal excision of soft tissue sarcomas in 5 years. So what are our options? You could wait and see if it comes back, 30 to 80% chance. Not ideal, but that is an option. Number 2, radiation therapy. Radiation therapy is available now in 3 different centers in Australia. We have it in Victoria at our hospital. SASH has it in Sydney, and BVSC has it in Brisbane. I think there's another hospital in Sydney that has access to a human machine. It reduces your recurrence rate to 20 to 25% in 5 years. Acceptable side effects. 15 to 17 treatments at our practice. This is an old slide. You're probably talking about 5,500 at our practice. Unfortunately, because they have linear accelerators at Brisbane and Sydney, you're talking about $12,000 to $15,000. And so it's certainly not for everybody to go up to Sydney or Brisbane, but we do offer a referral for all of our patients up there. We do end up treating a lot of dirty margins at our practice with our machine. Completely, our orthovoltage machine. I was talking to our radiation physicist today. She said that there are still dozens of those machines in use in Australia. It is old technology, but it is still very effective. She says that our machine is probably the best maintained orthovoltage radiation machine in Victoria, including all the human machines. So completely acceptable. This says we found a mass. Good thing we have weapons of mass destruction. All right, so radiation therapy, you do have side effects. So these are the types of burns that you're going to see. They peak at about a month out from radiation therapy, and by 2 months out, they're the skin's completely back to normal, except it's often hairless. So just be aware of that. It is a tolerable side effect. Is it something that I would do, if it wasn't necessary? No, but if it's a life-saving or limb-saving procedure, it's definitely worthwhile. And this is long-term. So often brown hair comes back white, white hair comes back black. And so it can be a little bit unpredictable. All right, metronomic chemotherapy is something to consider in patients with incompletely excised soft tissue sarcomas. This is something that everybody can do in their own practices. It's associated with the same recurrence rate as radiation therapy, 20% recurrence in 5 years. You use piroxicam and cyclophosphamide every 24 or 48 hours for the life of the dog. It's just as good as radiation therapy. Low frequency of side effects. What you see in 8% of cases is hemorrhagic cystitis because of the cyclophosphamide. You can also see GI, kidney, and bone marrow side effects. It is expensive because it's cumulative over time. If I had a 5-year-old dog that I was hoping to live to 15, that's a big cumulative expense over the lifetime. That might be one that I push more toward radiation therapy. But if it's already 10 or 11 years old or 12 years old, that might be a more reasonable option. You definitely want to look for kidney function before you start, because the piroxicam is toxic to the kidneys as well. So when you remove your tumor, so we've done all those steps up to this point, we've removed the tumor, you want to mark and assess your surgical margins. Margins predict local recurrence in many different tumor types. So what are we doing? We're painting the margin of the tumor with black India ink from the office supply store. And then when the pathologist looks at the sample, if they see tumor cells touching ink, they know that you've left cancer behind. Make sure that you tell your pathologist that you've marked the margins so they don't comment on some weird black pigment that's on the edge of the tumor. And literally, it's just black India ink from the office supply store. All right, so what if you got dirty margins? What are our options? So you send it off for histopath. You think you got clean margins, you get dirty margins. What do? Well, number one, just wait and see. Not a great option because most of them are going to recur. Radiation therapy, good option. Metronomic chemotherapy for soft tissue sarcomas, another good option. Recut is always your best option if you can. Recut has virtually 100% cure rate. My clean margin rate on recuts is 100% clean. Okay, so what you do is you treat your entire previous surgical scar as a brand new tumor. So two centimeters around the whole previous incision. So this is another example, back of a leg. And we've taken out the previous biopsy or the previous surgical incision, 2 centimeters around the whole thing. And then we did a lateral geniculate axial pattern flap to close it. All right, so there are 4 situations when a surgeon recognizes that complete excision could not be or was not achieved. Before surgery, that is the best time. During surgery, also called the O-ship phenomenon, not a good time, still not terrible. When biopsy results come back, really not a good time, although you still have a chance to do radiation therapy or metronomic chemotherapy. When the tumor recurs is clearly the worst time. So here's a amelanolic melanoma. I took one look at that and said, I am not going to get a clean margin on that. I'm not even going to try. This is one where I've cut into the tumor during surgery. This is one where we've got tumor cells touching our black ink. And this is one when we've had tumor recurrence. So before surgery is always the best time before you ever walk into the theater to realize that you're not going to get a clean margin. Okay. Where do you get cyclophosphamide for treatment. I'm not sure. I think we just get it from a regular distributor. I think it's widely available. We probably get it from CH2 or ProVet or one of those guys. All right, so chemotherapy, is it indicated? That's based on your literature review. The idea is to slow or prevent metastasis, increase our disease-free interval, and increase our survival time. Metronomic chemotherapy is good for preventing local recurrence, so that's the exception to the chemotherapy systemic metastasis rule. Maybe mast cell tumor, you can do chemotherapy as well. And this is a CT scan with our multiple metastatic lesions in the lungs.
Charles, we just had a question from the previous slide, I think from Jessica, what the second photo was, which I think that was the one you cut into.
Yep. What's the question? Sorry.
Sorry, what was the second photo from the left?
Oh, second photo from the left is, this is the ankle of a dog, and this is a mass that's kind of over the hock, and then we've gone to do a wide local excision, and then I've cut right into the tumor right there. Okay. So this is a dog. This is before I had my own CT scanner. So this is a soft tissue sarcoma on the flank of a dog. And I had a pretty good idea that it was pretty deep. So I'll just show you what we had to do to get a clean margin on that. So those are my wide surgical margins. I had to take all the way full thickness body wall to get my margin on that. So I'm looking into the abdomen, retroperitoneal fat. And that's the tumor sample. So that's the inside. So that's the peritoneum there. And we can see tumor almost poking through into the abdomen. And that's what it looked like when we closed. All right, I'll just go through this. And this is another one of our soft tissue sarcomas, wide local excision. So that's what it looked like when we were finished. And that healed by second intention completely. So you'd be amazed, you know, how well dogs can heal. So, and that's just another quick note. This is what it looks like as it's healing. So nice, healthy granulation tissue. We've got epithelium starting to grow in from the sides. Just a quick comment on electrochemotherapy. So this is something that we have at our practice. It's really interesting. What you do is with mast cell tumors, squamous cell carcinomas, soft tissue sarcomas, you give a dose of bleomycin, and the bleomycin can't enter the cancer cells because of the polarity. Then we shock the crap out of the tumor using this electrochemotherapy machine. It gives 8 pulses of 1500 volts in 300 milliseconds. So 8 pulses very, very quickly like this. And exactly that sequence causes little pores to open up in the cells temporarily. You have about 20 minutes, the chemo rushes into the cell, kills the cells. It's almost too good to be true, but really, really nice and effective for squamous cell carcinomas, small mast cell tumors, dirty margins on soft tissue sarcomas. If anybody has any interest in that, let me know. The machine, probably going to spend between $10,000 and $12,000. We've probably treated about 100 patients with it. It pays for itself. That's the machine right there. So we've got several different probes that we use to treat the patient. And I'll skip that. So this is a patient that had a squam on its nose. This is after a single dose of electrochemotherapy. It's about a month out. So this is my preferred treatment now for nasal squamous cell carcinoma in cats. So give you a challenge. That's the end of the lecture. Try to apply the 10 commandments to your next cancer patients from now on. So really think about, you know, communication with the owner, biopsy, literature review, staging, communicate with the owner, surgery, check your margins, chemotherapy, communicate with your owner. Okay. I'll leave it at that. Matt, do you have any comments or questions?
No, Charles, just apart from thank you for a wonderful presentation, very informative as always. And yeah, no, thanks everyone for attending. I've placed some information in the chat around Timeless and my email address as well. Again, it's just mjones@remsystems.com.au if you wanted to reach out. As noted previously, Charles is available through the Timeless platform for consultations. Yeah, so thank you very much.
That's right. And if you guys forget Matt's email or anything like that, just send me an email. Most people have my email address at info@southpaws.com.au or sequence1@mac.com. And you can send me an email and I'll put you in touch with Matt. So
thanks, Charles.
Stay on for just a couple of minutes and just make sure there aren't any more questions. And then hope everybody has a great rest of the night and a great week. And if you're interested in our VetDojo rounds, if you haven't attended in the past, just maybe try to get on our mailing list. You probably are already on there if you received this email, but keep an eye out for the announcements. We do VetDojo rounds every 2 weeks, usually on a Thursday, and it's discussions similar to this about all different topics, orthopedics and soft tissue surgery and that kind of thing. So